Welcome everyone to today's webinar, How to Mitigate the Risk of Clinician Burnout, New Survey Results Revealed. I'm Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the link you used to log into today's webinar to access the recording. It is now my pleasure to start today's webinar by introducing our presenter. Teresa Niblett is the Director of Clinical Informatics at Peninsula Regional Medical Center. She has nearly 20 years of experience in healthcare, previously working as a critical care nurse, interventional radiology nurse, and Director of Cardiovascular Surgery Services. For the last 8 years, in her informatics role, Teresa has supported patient care initiatives, information services, and multiple vendors in developing, implementing, and optimizing systems to enhance care delivery. She is also board certified in informatics nursing from the American Nurses Credentialing Center. At this time, I am pleased to turn the floor over to Teresa to begin today's presentation.
Thank you, Mackenzie. Hi, everybody, and thank you for making time today to join this presentation. It's a privilege to share on this important topic. During this hour, we're going to discuss what is meant by clinical burnout. Next, we'll discuss the results from a survey conducted this past spring to get a deeper insight on what clinicians think about burnout and their suggestions to tackle it. And last, I'll share some strategies being used at Peninsula to improve clinical workflows which may alleviate some burnout symptoms. So, clinical burnout. What is clinical burnout? By clinicians, I'm talking about the entire team providing care. This includes physicians, physicians' assistants, nurse practitioners, nurses, respiratory therapists, physical medicine colleagues, case managers, social workers, all who are working in the complex healthcare environment today. And what is meant by burnout? In the 2015 AHRQ's annual perspective, burnout is referred to as a syndrome of emotional exhaustion, depersonalization, and decreased sense of accomplishment at work. This results in symptoms of overwhelm, fatigue, exhaustion, cynical detachment, and feelings of ineffectiveness. The symptoms persist and can progress. Why is burnout occurring? Many variables can contribute to healthcare burnout. One of the top factors called out by many professional organizations is work overload. Today's healthcare landscape is fast-paced, high energy, high stress. The work is often emotionally physical and mentally draining. In the last 2 decades, many initiatives at the national level have put increasing pressure and stress to reform healthcare. In 1999, the Institute of Medicine published To Err is Human. This shed light on poor healthcare outcomes and a call to action to change it. The American Recovery and Reinvestment High-Tech Act and the Affordable Care Act resulted in increased focus to capture more data by clinicians electronically in order to better measure quality and costs and share data. So looking at burnout more closely, there's a gap. Sometimes it's subtle, and sometimes it's quite significant, between the care clinicians want to provide and the care they're able to provide. Each day, doctors, nurses, and allied health professionals are circumnavigating demands to satisfy business requirements that may intend to have the best interest of the patients in mind, but don't. It's a broken system. Navigating these competing demands can result in moral injury. Some groups are emphasizing now how moral injury and burnout are not the same. Moral injury is damage done to one's conscience or moral compass when that person perpetrates, witnesses, or fails to prevent acts that transgress one's own moral beliefs, values, or ethical codes of conduct. When a doctor, nurse, or any healthcare worker knows or feels like there's more to do but they have obstacles to getting it done, it impacts them on a different level. This term has been used to describe what soldiers in war have experienced, and some public figures have equated some healthcare settings for clinical staff as war zone-like. Working harder, not smarter will not fix burnout or moral injury. As mentioned, this idea of impact on caregivers is being talked about in many forums and being called different names. The bottom line is there are many opportunities for improvement through partnership, and there is hope. This slide calls out some of the impact burnout can have. It's the opposite of what most healthcare goals are targeting. Most folks I encounter in healthcare, be it a patient, a colleague, or a partner, desire to live and serve in healthy communities. We want to work efficiently and effectively towards better outcomes and be cost conscientious. We have physicians that are leaving practice or people that are interested that are avoiding coming in. We have nurses that are projected to retire and a shortage of both doctors and nurses. This past spring, a national survey of U.S. healthcare organizations was conducted to discover what caregivers' perceptions of burnout are and what solutions are helping to address burnout. This survey was administered online. 474 responses were received from hospitals and healthcare systems across the United States. Here's some information about Spoke. Spoke is a global leader in healthcare communications. They provide services to over 2,200 hospitals. They offer an enterprise communication platform, and their team is focused on innovating solutions to enhance communication workflows. The goal is to eliminate steps and save time for clinicians. Whether it's reducing steps to calling codes, be it code blues or code STEMIs, making consult requests, answering nurse calls, or just general care team communication, Spoke has a desire to innovate in this space. In searching for problems that enhance communication solutions and what Spoke could do to provide some relief, the call to tackle burnout, the Spoke team took notice of a paper published this past winter by 4 medical professional societies. It's called A Crisis in Healthcare, a Call to Action on Physician Burnout. This publication, called Physician Burnout, a Public Health Crisis. The authors give great etiology of the problem, describing Don Berwick's eras of healthcare. It recommends that hospitals support proactive mental health treatments, improve EHR usability, and also appoint a chief wellness officer. The Spoke survey questions were inspired by this paper. So who took the survey? The majority of the respondents, 78%, represent physicians and nurse roles. 5% identified as a clinical leader. This could be a CMIO, a CMO, a CNO, a CNIO, or a CIO. And 17% describe being in a clinical role other than a nurse or a physician. When asked, is burnout a public health crisis? 92% of participants' response was, burnout is a public health crisis that demands urgent action. 70% responded that they experienced the symptoms of burnout themselves, considerably or a great deal. Respondents were asked how often the topic is discussed at their organization, and almost half said rarely or never. 26% said occasionally, 18% said often, and 9% said they're always discussing this. So what prevents clinicians from seeking help? Respondents, 65% stated lack of attention or resources. 56% said stigma, and 54% stated privacy concerns about their own health information. Stigma and privacy concerns about health information also parallel the comparison made earlier between frontline healthcare workers and soldiers with moral injury. There is angst in being seen as needing help or weak, and what that might imply in performing duties. When asked, does increased or ineffective technology contribute to the risk of burnout? 90% agree, and only 4% disagree. How does technology contribute to burden? The number one response by surveyors was burdensome or increased workload. This correlates with the expansion of the triple aim to the quadruple aim: better health, better healthcare, lower costs, and reduced burden. The other popular response included poor integration into clinical workflow, poor implementation, and poor adoption. The top suggestion by participants for technology improvement include reduce documentation burden, increase usability and workflow, find solutions to increase collaboration between all stakeholders. This is an ongoing and growing call to action. Each day, new initiatives to improve quality, safety, financial, regulatory, or risk initiatives introduce more data for caregivers to collect and enter. Much time is spent rumbling over what data is really needed and why it's needed. What is the best way to collect it, and who really owns capturing it, and when and who? It's also a challenge to find processes to monitor and validate. Is the data correct, and is it meeting the initial need? At a national level, there are initiatives like Patients Over Paperwork and streamlining and harmonizing reportable measures aiming to try to provide some relief. Many physician and nursing-focused teams through the IOM, the NAM, and professional organizations are contributing to national-level focus groups. Honing in on the EHR, the Crisis in Healthcare paper suggests improving EHR systems as one of the top 3 recommendations to curb burnout. It calls to improve interoperability, reform certification standards, increase engagement of the frontline staff that are using it, and reduce the amount of required documentation. Other suggestions for improvement include supporting proactive mental health treatment and support, appointing an executive-level chief wellness officer, and avoid promoting self-care strategies like yoga or mindfulness that don't actually address structural problems. It's a systems issue. Will these suggestions work? Survey participants, 95% agree improving EHR usability will at least be somewhat helpful. 87% support mental health treatments, and 72% believe in appointing a chief wellness officer. If you'd like to read more, you can download the full e-brief at spoke.com/clinical burnout. So now I'd like to share a little bit with you about my organization and the work that we have done and we're continuing to do to improve communication and alleviate some of the burnout our team is experiencing. Peninsula Regional Medical Center is a 289-bed hospital located in the heart of the Delmarva Peninsula and a part of the ever-expanding Peninsula Regional Health System. As you can see on the map here, we're right in the heart of the Delmarva Peninsula. We serve 3 states, the southern part of Delaware, the eastern shore of Maryland, and Virginia. We also serve many tourists who visit each year. Our ER is very active. We partner with and employ hundreds of physicians. We have many joint ventures. We went live with Epic, enterprise-wide, almost 3 years ago, and we've been customers of Spoke for nearly 2 decades. While we have collaborated with the Spoke team for many years to improve communication with our teams, a little over a year ago, we entered into an innovation partnership to give our clinicians the opportunity to influence and design and priorities. Communication challenges abound. When I started my career, communicating with other departments and specialists took many steps and many minutes. We had to look up numbers in paper directories and/or call the operator. This resulted in delay in patient care and anger and frustration. Sometimes the wrong people would get pages, or sometimes we wouldn't get called back, not understanding that who we had contacted wasn't the correct person. Initiating different code calls could take several minutes, with difficulty in determining the recipients of the code or alert. We had to rely on overhead paging. Many of our staff started to collect devices, doctors, nurses, therapists, carrying portable phones, pagers, and constantly accessing mobile and desktop computers. How can we do more with one device or less devices? How can we improve the ease of use, the durability, the connectivity? Our early work deploying some bespoke solutions allowed us to be much more efficient at accessing a reliable staff directory and a paging directory. It enabled us to quickly message and callback numbers or messages using alpha pages. We've been able to increase notification about critical events to multiple stakeholders instantly and get responses to critical events. Our organizational performance improvement methodology is DMAIC. When we identify a problem, we try to start with the clinical use case. We form multidisciplinary teams to better define and measure problems. We research the literature and best practices. We analyze gaps. We analyze and we do process mapping to better see those gaps. Looking at the current state versus the ideal state, we ask, can a technology tool be enhanced to support improvements in the clinical use case defined? Is there a good business case? What's the ROI? And is that as objective as we possibly can make it? In this picture, we've got one of our teams. It's a surgical unit, and we've got some of our staff nurses and our PAs and NPs that support that unit a lot, and they've been using one of the new Spoke products to improve their ability to communicate. And this has been a huge satisfier to this team because they've been able to message back and forth. They don't have to wait to see if the provider got the page. They can see when they've read it, and they don't have to wait for the provider to call back, and the provider doesn't have to wait on hold or try to find the right person. They can just message right back. We have the Spoke Care Connect platform. It combines a contact center solution, centralized and integrated directory and scheduling, alarm management, secure messaging, and is able to fully support multimodal paging, real-time communication among all of those responsible and engaged in patient care. We're able to leverage this not just for clinical care communication, but for disaster or urgent communication matters. It's been a great tool for drills and also for real-life events, whether it's regulatory bodies showing up to pay us a visit or an emergency management type need. With the Spoke team, we're partnering to improve how care teams securely access real-time information from clinical systems and send secure messages on mobile desktop devices to manage workflows, alerts, and tasks. Let's take a closer look. By now, you should have a good understanding of the value of communication, but you may be wondering what is meant in practice. How does it enhance clinical workflows and care team collaboration exactly? A robust and fully integrated healthcare communication platform fills the communication and collaboration gaps in the EHR by connecting care teams and systems to improve workflows and deliver information quickly and securely into the hands of those who need to act on it. One use case that we've been proud of is the ability to send information to our on-call cath lab team. They're able to get, with one action of the operator, information on a patient that needs them to respond. Some other tangible examples include our Code Blue initiative. We were able to quickly send Code Blue information to our response team and eliminate some of the overhead paging that was happening. Another project that we're working on is to integrate nurse call bell with the mobile phones of the staff. This allows the nurse, nursing assistant, and charge nurse to better collaborate, and get responses to the patients as quickly as possible. So far, we've seen a huge boost in satisfaction by providing access to contact information and on-call schedules anywhere, and to receive messages on the device of choice of our providers. So now they don't necessarily have to carry a pager. They can choose to use an app, or they can get it through SMS. And as I mentioned before, we've been able to reduce our code blue rate by 70% using the Spoke Care Connect EHR integration, which notifies care teams of potential patient deterioration and allows them to intervene early. We're working to improve patient satisfaction and satisfaction throughout the facility, as well as improve clinicians' efficiency and satisfaction with communication tools. Will this solve the problem of burnout? Not alone, but we hope to demonstrate in the coming months how it will continue to help our clinicians be more efficient. And with that, I went through that a lot faster than I anticipated. I'm going to turn it back over to Mackenzie for questions.
Great. Well, thank you, Teresa, for such a fantastic presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. The first question is from an audience member who asks, is the SMS a secure platform?
No, it is not a secure platform. So we are working to continue to roll out a secure platform that we have, in addition to innovating a more robust secure messaging platform.
Wonderful. Thank you for clarifying that. The next question is, how do you get doctors and nurses to adopt new technology at your organization?
Well, as I mentioned, understanding the clinical problems we need to solve, what are the problems that the doctors and the nurses say that we have, and we validate that technology can actually assist. We then work to build relationships with the colleagues and include them in all phases of the project. It's people, it's process, technology. We have to provide clear and concise information as we're rolling things out. It's not just a one-page tip sheet that goes out. It's iterative. It's back and forth. It's actually finding them where they're at if they can't come to you and giving them the information they need to be successful. We work very hard to keep communication channels open and really listen. We're very blessed here to have a dynamic medical staff team and nursing team, and they're very open and honest with us about what's working and not working. And we work hard to establish trust and take action to mitigate the risks before they occur, or take action right away to try to address the concerns of the things that they're experiencing.
Wonderful. Thank you, Teresa. Another audience member wants to know, how did you measure patient satisfaction?
So we used key questions of our NRC picker results on specific units, and after we did a baseline measurement, and then after we implemented the intervention, we reassessed, and we continue to assess that. It's not always clean. We did initially see an improvement, but we know that some of the questions that we picked, there's many variables that can influence those responses, but it's a good idea.
Great. The next question is, do you also use Epic Secure Messaging?
No. At this time, we are not using Epic Secure Messaging the way that they promote it. We have looked at that, and the reason that we chose to go with Spoke messaging is because we find that a lot of our communication needs, while very patient-centric, some aren't. And there was some reservation about having, information about a gun or an EHR outage or those types of things in the medical record.
That makes sense. Thank you. I'd also like to remind the audience that they are more than welcome to ask questions. There should be a Q&A box on your screen, and you are more than welcome to submit any questions there. The next question is, what are you doing to reduce the EHR documentation burden, which the doctors pointed to as a chief contributor to burnout?
Great question. So I partner with the CMIO. He's been tackling physician concerns, and he's really pushing to reduce unnecessary BPAs or question and challenge things that aren't necessarily something that needs to be done by a physician. For nursing, we've heard loud and clear some of their concerns with unnecessary charting. We recently completed an optimization project of our head-to-toe admission assessment, and we're able to reduce that by 33% and improve staff satisfaction by survey and actually save them a little bit of time.
That's fantastic. Another audience member asks, do you have any data that shows that your specific technology has reduced burnout, provider turnover, or suicides?
No, not at this time. Through our innovation partnership, we are looking at several different metrics, but because this isn't fully deployed, we don't have any outcome data yet. And I do believe that our CMIO and our Chief Quality Officer, both of which are physicians and very passionate about this topic, are interested in trying to make a dent in.
Absolutely. The next question is, have you looked at RPA tools as a possible solution?
Not that I'm aware of, not at this time.
Great. Well, let's jump to the next question then. What types of devices are you using, BYOD or hospital device?
Honestly, right now it's a mix. Our leadership and medical staff have been using a BYOD model for quite some time. We've really held the line with having our hourly employed staff use their devices. We've got some pretty strict HR policies in place that prohibit that. But we have had a couple of use cases or pilots that are purely voluntary. So we've had some staff in our critical care unit, and as I mentioned, some staff on one of our med-surg units that have voluntarily agreed to download an app on their phone in order to test out how effective this is at alleviating some of the symptoms that have been presented. We are actively working on introducing smartphones to replace our wireless phones that we currently have. We actually have a project that's been underway for a little less than a year that's going to be kicking off August the 20th. We'll be deploying smartphones on one of our first med-surg units.
Great. Well, the next question is about charting. And this audience member is asking, do you have recommendations for answering the what do I have to chart question? We always say if you don't chart it, you didn't do it, but it would be nice to have guidance or training.
Yeah, that's really tough. And depending on who you have in the room during that discussion, you can get different answers. One thing that we've recently been looking at is a presentation that was given by a nurse at a nursing conference I attended last month in Baltimore, where they developed 10 to 12 questions that they asked. You know, is it a regulatory requirement? Is it, nursing practice or physician practice, whatever the discipline is that you're talking about, that this is something that individual is going to use in this encounter to care for this patient, develop that plan of care, all the way through to does it affect cost and reimbursement, or is it a risk management issue, asking questions around who really should be collecting it. Is it the responsibility of this role, or is it just a convenience that, some other external stakeholders tried to push upon that role? And they developed a rating score which helps them to more objectively assess is this question really necessary to be asked? And of course, you use the experts. You pull in your risk management person that is familiar with the RCAs or the legal aspects. You pull in your regulatory experts that know those conditions of participations and joint commission requirements inside and out. And you get those professional practice people that know, what is the nursing practice or the physician practice or the allied health practice, and you vet that. We struggle, and I think a lot of organizations struggle with that. If it's not documented, it's not done. But at the end of the day, you have to make choices. Some things are just the standard of care. If we did document every single motion that we did all day long, there would be no time left for patient care. Hopefully that helps.
Yeah, it definitely does. Thank you for elaborating on that. I have a related question here from an audience member who asks, do you use any automation tools to reduce the stress of data entry?
Yes. I don't think that we're quite where I would like for us to be, but some of those tools are costly, and we have to make choices about how we spend our money. But we do have some device integration. There's a lot, our physician staff is using, dictation, or not dictation, but voice recognition. Nursing is very interested in pursuing that. So, yeah, there's a lot of interest around getting more patient-generated data, for specific things. That's not really automated, but just looking at other ways that required information can get entered. We're constantly increasing the access to different care team members to information outside of the facility, some of which can be consumed.
Wonderful. Well, the next question is, have you appointed a chief wellness officer, and or does that individual need to be a clinician, and what are the criteria for this role?
That's a great question. No, Peninsula does not have a chief wellness officer, though we do have some programs that could support what a role like that would be promoting. We have a wellness program through our cardiac and pulmonary rehab. We have an employee assistance program through our HR, and I know that both of those programs get used. We've done a lot of work to help improve access to our staff to different wellness programs. There's been talk of it, but again, being a smaller health system, our resources are maybe more constrained than some of the bigger academic medical centers or the bigger health systems. So that's what I know about that.
Wonderful. Well, thank you for elaborating. The next question is about cost effectiveness. This audience member is asking if you looked at that, and if so, what dimensions of effectiveness did you measure over time? What was the time interval before you assessed the outcomes?
We haven't, but that's a great question. It's really cost in terms of time, time that staff are spending and, what that costs. So nothing really solid yet in terms of savings. But, we know about how much different providers make and how much time that they're spending, and if we can give them time back, that is cost saved. That's also cost saved in terms of patients getting better quality of care. I think I read something recently that was saying that the average provider only spends about 13% of their day actually in physical proximity with a patient. I don't think that's counting proceduralists, but that's incredible. In nursing, it's the same way. We know that our nursing spends about 3 hours a day in our EHR, and probably even more time on the computer because so much is tied to the computer. So that's time not spent doing direct patient care. And We've done some preliminary work trying to understand the FTEs that could be repurposed or used differently, but nothing, in terms of outcomes yet for that.
Wonderful. Thank you for touching on that. The next question is, do you know of an external support system for clinicians experiencing burnout, whether it be a website or a support group, and should they be hesitant on utilizing your hospital's internal EAP?
That's a great question, and I know that there are a ton of resources available through professional organizations. In terms of using the employee assistance program, whether it's here or it's any, I guess there's always concern that there's not privacy there. But I have trust and confidence in our health system. I know that they take privacy very, very seriously. So I don't think that there's risk there. I personally have used that services before, early in my career. I know of other people that have shared that they've taken advantage of it and that they were satisfied or maybe not satisfied. I'm trying to recall some specific sites because in researching for this presentation, I did come across a lot of things, and I can't recall anything right off the top of my head. But there are a lot of individuals or even groups of professional organizations that have called out ways that whether you're a nurse or a doctor or an allied health professional, you can get involved that have resources out there.
Great. Thank you, Teresa. Another audience member is asking, how do you use your EMR to help physicians sign off on their charts in a timely manner?
I am not as familiar with that workflow, so I'm going to have to pass on that question. I'm pretty sure we use some in-basket messaging, and I've been in the room when we've had discussions about it, and I know that we've come a long way with where we used to be, but it's been designing and then working with the different provider groups to get familiar with how to use that EHR workflow.
Yeah, no worries at all. We can also follow up with audience members individually to make sure all their answers are in fact answered. So let's move on to the next question, which is, do you use scribes for data entry?
Yes, we do have scribes. We've had scribes in our emergency department for many years. And then in some of our ambulatory practices, they've been revamping the care team delivery. And I recently had my yearly well check at one of our providers, and I wouldn't even consider it, just, scribed. The care team member, the technician that did my intake, put the information in and, did the screening. And then when the physician came in, she reviewed everything that she had collected, calling out the problems that had been identified. And he asked some questions, and I was so impressed. So she was doing some data entry for the physician, but it was really more of a partnership in caring for me. It wasn't like you're just walking around and you have no part in the care delivery.
Great, and we have a couple questions here about the Spoke platform itself. The first is, do all disciplines use Spoke?
So in some ways, yes, because Spoke has a whole suite of solutions. All of our care team members have access to the smart web. So they're able to very quickly access that tool, and they can look up phone numbers for individuals or departments. They can also see on-call schedules and actually page providers or administrators or other folks that carry pagers right through that system. That solution is one way, unless the user knows their login and can log in. We have couple hundred people using the Spoke mobile app, and we use that for two-way paging, and it's great. But there are, some improvements, some expansions that our team has wanted. So the new solution that we're helping to innovate is called Spoke Go. And that app, we have about 200 users, and they are able to do two-way messaging and see when the person they're sending the message to has seen the message. They're able to download secure pictures. They're able to do group messages. And then there's also a task function where other information can come in. As I mentioned, we're piloting the nurse call integration, so the nursing assistant and/or nurse or charge nurse can take action on that request right away. It saves them time before they go in the room to find out what the patient wants. And then, of course, our switchboard operators, they have the Smart Suite console. They're able to do a lot very efficiently. They're getting calls constantly from inside and outside of the hospital, and they're responsible for sending out a lot of these mass messages, whether it's for a joint commission visit or an emergency drill, or it's paging these different code teams that we talked about.
Great, and let me ask you a follow-up question to that. Is the messaging platform of Spoke similar to that of Vocera?
I am not familiar with the Vocera tool, so I can't answer that.
No worries at all. One other question is, how does Spoke differ from other programs out there, such as SmartWeb, if you're familiar with that?
So I'm familiar with Spoke's SmartWeb, and SmartWeb is more of a computer-based program that allows you to see, as I mentioned, all of the employees that are in it, all of the departments that are in it. You can also go and see different teams, groups, individuals that are on call. The SmartWeb platform, I think one of the goals of Spoke is to make all of that information readily available in their solution, but they're not quite there yet.
Great, thanks for touching on that, Teresa. We've got another interesting question here, which is, did you encounter resistance among members of the medical staff with regard to sharing personal contact information such as cell phone numbers?
Yes. Now, with the Spoke applications, well, let me back up. So through SmartWeb, the switchboard and communications offices does a very, very good job of keeping cell phone numbers private. So if an individual is messaging a provider that has chosen to use the app or use SMS, they have no visibility to what that provider or really any user's cell phone information is. And there's some providers that aren't as concerned about that. We actually have a handful of providers that give their cell phone numbers out to patients. But that is a concern. Using the apps and communicating back and forth, it's not like you know what that provider's phone number is. With Spoke Mobile, they're able to indicate what their status is if they're not available, much like they can with the paging. If somebody tries to page them through SmartWeb, you can see that they're at a hospital, unavailable. There's no sharing of information. Another concern is around data usage or, battery, burning the battery up. And we've been able to talk through and get them to try it out and see for themselves that it's not a problem in those regards.
Great. I think that's helpful for our audience to know. This next question is from an audience member who's asking, is Epic willing to share the improvements to your installation that you've implemented with other health system clients of theirs?
I'm not sure. They probably have to ask Epic that question. Oh, I just got a message that our moderator accidentally hung up, and she'll be right back. I apologize for that if you guys can hear me.
Hi, all. I'm back. So sorry about that. Let's dive into the next question, if that sounds good to you, Teresa.
Sure.
Perfect. So the question is there an ROI or pro forma document you can share that might help influence C-suiters to adopt the spoke system?
Possibly. If you want to send me your contact information, I'll review with my leadership team if there's support in that.
Perfect. Thank you. And the next question is, if you consistently have a higher volume of patients than your staffing level, how do you fill the needs when people want their day off more than additional money?
There's a lot of ways. Our nursing leadership has really been focused on trying to improve our ability to flex up for a long time. We have utilized different models of mobile and flex staff, and there's been occasions where we've had to hire travelers. We don't do any type of mandatory overtime. We do have a lot of staff that like to work extra shifts. There are occasions where we might have to max the staff-to-patient ratios. But we do have a leadership that's very supportive of trying to give their staff the time off.
Well, that is great to hear. And the next question we have is, what would you recommend as a good first step when starting to implement new technology in the hopes of reducing burnout?
Again, I think it's a thorough assessment and a clear definition of the problem that's trying to be solved. You know, saving doctors and nurses time has been a constant goal here at Peninsula. You know, where is the time wasted? Really trying to get down into the weeds of it and make sure that you're tackling the right thing. And taking a mix of subjective information, but also looking for ways to make it objective. There are times where it may not be what the complaint says it is, but sometimes it's not possible to get objective data. If it affects patient care and patient outcomes, or even saving them time, that is going to have an indirect or sometimes even very direct effect on improving the patient care and patient outcomes. So again, a good first step would be really making sure you're defining the problem and understanding it so that when you come up with that solution or you want to try that solution, you can see, is it making a difference or is it not making a difference?
Wonderful. Well, before we go ahead and end today's presentation, I just wanted to turn the floor back over to you, Teresa, one more time to see if there are any final thoughts that you'd like to share.
Thank you so much. I just want to thank everybody for their time today and talking about this serious topic. By no means is it solved yet. We still have a lot of work to do, but I'm optimistic that if we continue to partner and innovate and hone in and put the work in, that we will be able to make a difference and see improvements in not just our clinicians' lives, but the patients that they serve.
Wonderful. Well, that is all the time that we have left for today. I want to thank Teresa for her excellent presentation and Spoke for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.